you've been well. In this half an hour video, I'm trying to introduce to you the new cardiovascular guidelines and the new calculator. There is a fair bit of the new stuff in the new calculator and the guidelines that we need to cover. And I think many of them might surprise you because there are quite a few interesting things that I've realized with the new calculator. So we try to be fast and efficient. As you know, the old calculator, which was around from 2012 until a couple of weeks ago, is now retired. And now we have the new calculator, which has come out only a couple of weeks ago. The new guidelines have similarities and differences. All in all, I really like the new guidelines a lot better because there is less gray area. Things are more straightforward and they don't really have areas that you don't know what to do. Remember, this is for primary prevention of cardiovascular disease. Anyone who does have a known cardiovascular disease is not going to benefit from this calculator. This is for people who never had any cardiovascular disease whatsoever. As you may remember from the old days, we had 3 patients, Joan, Joanne, and June, all the same age. And we presented these 3 lovely women to you just to see how the use of calculator can help us to decide which patient would benefit from statins and antihypertensives and which patient would not need any of those, and we just need to introduce them to a healthier lifestyle. So going back to the old calculator, as you may remember, someone who was 63 and diabetic straight away would have been a high risk person for cardiovascular disease. Without the use of calculator, we could make a decision to put them on statin and antihypertensive, regardless of the level of the blood pressure and the lipid profile, because our aim was to reduce the risk of cardiovascular disease in the next 5 years from above 15% to anything lower that we can potentially achieve. In the new guidelines, I would explain to you that this patient would not be qualified for any of those medications, which may surprise you, but we'll get there in a minute. In the old guidelines, we had the intermediate risk group, which we had to put on lifestyle modification initially for 3 to 6 months and eventually on medications for the high blood pressure or the high lipid profile. And a low risk person under 10% did not need to be on any medication. We just needed to treat them with lifestyle modification unless the blood pressure was over 160 on 100. This is all old guidelines, just refreshing your mind. And we had some parameters in the old guidelines. All of them are still there in the new calculator, except for the LVH on ECG, which has been removed from the new calculator. So with the new calculator, we have a lot more factors and variables that we need to count for. Some of those include history of atrial fibrillation, the postcode, and the socioeconomic impact on the patient's lifestyle. The use of medications, CVD medications in the form of lipid modifying medications or blood pressure medications or antithrombotics need to be counted for as well. And more importantly, with the diabetes, if we want, we can put a lot more variables in for our diabetic patient, including years from diagnosis, HbA1c, urine ACR, eGFR, BMI, and the use of insulin in the last 6 months. And that would give us a more accurate results in terms of the calculated risk for cardiovascular disease in the next 5 years. The other difference is that in old calculator system, we had 10%, 15% and above. So anything less than 10 was low risk. They have cut that down by 5% in the new calculator, which is not based on the Framingham data anymore, which was an American data. In the new one, we cut that by 5. So less than 5% is considered low risk. 5 to 10 is now intermediate, and anything above 10 is considered high risk. The explanation from the Howard Foundation is that generally the risk of cardiovascular disease have come down a lot in Australia over the last decades. If we count from 1960s, by 80% it's come down. If we go in the last 10 years, it has come down significantly as well. So that 5% reduction still is going to target the same proportion of the population, if that makes sense, because the whole risk and incident has come down in the whole country. So these are the variables that we put in if the patient has diabetes, like I said. Like the old calculator, some of the factors which we know as risk factors for cardiovascular disease are still not counted for, even in the new calculator. For example, BMI, we know it's a risk factor by itself, but the argument is that BMI's impact is going to show up as high blood pressure, perhaps as diabetes, and as deranged lipid profile. So we will see the impact of high BMI in the calculator eventually, so we don't have to put that in separately as an independent risk factor. The left ventricular hypertrophy has been removed. LDL and triglyceride has never been part of any of the calculators, the same as impaired glucose tolerance and fasting glucose. And waist circumference, for the same reason that BMI is not calculated for, is not in old or new calculator either. Some of the features have been added as mandatory variables that we need to put into the calculator, and they are postcodes, use of CVD medications, and atrial fibrillation, like I said. And some others have been added as reclassifying factors, which once you have your calculated result as the percentage, you need to consider those reclassifying factors and consider, moving up or down the risk level. Those are family history of premature CVD, ethnicity, severe mental illness, and stage 3A CKD or microalbuminuria. If any of those are present, or if a combination of those are present, it allows you to reclassify patient up, or with the ethnicity, for example, to reclassify them down. So the beauty of the new calculator system is that you don't have to remember anything in advance. You can just click on the calculator and go by the flow, and you won't miss on anything, because whatever is on that page is going to cover everything you need to know. So no pre-reading is needed if you just want to use the calculator, which is amazing. So first of all, you need to consider the two automatically high risk situations before you enter the calculator. Luckily, they're already there. So moderate to severe CKD, which are certain CKD levels, as it's shown in here with the EGFR and macroalbuminuria. They put the patient straight away in the high risk category, so we don't need to use the calculator anymore. Similar to familial hypercholesterolemia, which we used to have in the old system as well. So once you exclude those two automatic high-risk situations, then you need to put the age in. The beauty of the new calculator is that it's expanded by 5 years. So in old calculator, we used to have it used only for up to age of 75. And now we can use it up to age of 79 for all different groups. We can also start using this calculator a lot earlier for people from First Nation background. We can start at age of 30. And anyone with diabetes, we can start using the new calculator from age of 35, which basically covers a lot bigger section of population. Sex at birth, the history of smoking. If someone stopped smoking before 1 year ago, or beyond a year ago, we can put them as previous smoker. If someone stopped less than a year ago, then we still put them as currently smoker, unless they go beyond 1 year of quitting. You have a choice of putting the ratio of total cholesterol to HDL, or just put them separately. And with the new guidelines, you don't have to look for fasting lipids. If you have non-fasting lipid profile, that's as good as the fasting one for the purpose of calculator. The Australian Society of Pathology doesn't really care about fasting and non-fasting lipids. They say if you're looking for the cardiovascular profile, the ratio will remain very much the same, no matter if it's fasting or non-fasting. With the blood pressure, the recommendation is to have the two in-clinic blood pressures and put the average of the systolic blood pressure in the calculator. If you don't have the two separate in-clinic blood pressure readings, you can use the data from your home blood pressure or ambulatory blood pressure readings, but the recommendation is to convert them to the in-clinic. And not that I could find any calculator to convert, but if you're just going to go by the criteria for hypertension diagnosis with our hypertension guidelines, usually the difference is something around 5 millimeter of mercury between ambulatory or home and in-clinic blood pressure. So that would help you to convert the two together. Pretty much the majority of blood pressure modifying agents, any lipid modifying medication, or any antithrombotic in the form of antiplatelet, anticoagulant, are considered as CVD medications. And if patient is on any of those, you need to tick the box. And I'll show you in my examples how they would impact your risk profile or calculated risk. Any history of paroxysmal or persistent AF, no matter when, gets a tick in yes box. And this calculator is only for people with type 2 diabetes. So for type 1 diabetes, the data is not validated and it's not going to help you. So you only tick yes if the patient has type 2 diabetes. The postcode and the socioeconomic level of the patient is now considered as a risk factor. So low socioeconomic should, or even any level of socioeconomic should be there, but low socioeconomic normally pushes your risk level slightly higher, and that is usually because of the access to economic resources, to healthier food, to facilities for exercise, which are considered into the CIFA calculator. We talked about the diabetes and what we can add to our calculator for diabetic patients to get more accurate results. And once you have your result calculated, now another step is that you can reclassify your patient based on extra risk factors that can bring the risk down, like good ethnicities, or push the risk even in a higher level with some other ethnicities or some other risk factors that I'm going to explain to you in the next few slides. So calcium scoring, for example, particularly for patients who are in the intermediate risk group and more towards the closer risk to the 10%. So if someone is 9 or 8 and has 1 or 2 reclassifying concern or risk factors, then you may consider ordering a coronary artery calcium scoring, which is not covered by Medicare. It costs about $200. But in certain situations, when you are tossing between intermediate or high risk, because the calculated risk is a bit borderline and you do have 1 or more reclassifying risk factors, that would help you to decide between which group that you need to allocate the patient to. So if the calcium score comes back as 0, that can put your mind at ease to some extent. So you'll be less concerned about pushing the patient to the higher risk, and you can wait for at least 2, maybe 5 years and do another coronary artery calcium scoring or watch the risk factors. If the coronary artery calcium is above 99 units or more than 75th percentile, then obviously you will be more comfortable in reclassifying another degree up to the high risk and put the patient on both statin and antihypertensives unless it's contraindicated or inappropriate. So in other situations, the coronary artery calcium scoring is not going to help you. If the patient has cardiac symptoms, it's not recommended to use calcium scoring. If the patient is already in the low risk category, there is no point. If they're not even close to high intermediate, if they're low intermediate, it's not going to help you. So it's only for the situation that you are tossing between intermediate and high, which is going to be a game changer in terms of putting patient on medications. And when you have multiple risk factors which are not calculated for in the calculator. So certain ethnicities, specifically East Asian ethnicity, would help you to bring the risk level down. First Nation people, Maori, Pacific Islander, and South Asian ethnicity would push the risk level usually higher if the patient's calculated risk is close to the borderline. Like if they are 8 or 9%, but they do have the ethnicity risk profile, then you feel more comfortable to push them one level higher in terms of risk. Same as family history of premature CVD, and for the purpose of these guidelines, any first degree relative, female under 65, male under 55, would consider as a risk factor. Any CKD at GFR between 45 and 59, which is 3A of CKD classification or staging, or any microalbuminuria would consider as a reclassifying up, and severe mental illness, which by definition is any episode of mental illness over the last 5 years which required specialist input. Even if the patient did not end up getting a specialist input, if you think that they're required to have the specialist input, that would be enough to reclassify them one class higher. If someone comes back as low risk, then we can recalculate the risk again in 5 years. In intermediate, we recommended to reassess the patient in 2 years and see if they've been pushed up to the higher risk. And for someone who is in high risk, there is no point recalculating the risk, because anyone in high risk will remain in high risk forever, and we like them to be treated for high risk forever. This we've already covered. This is basically how to treat. And when it comes to management of low, intermediate, and high risk patients, pretty much everything is the same as the old calculator. I couldn't find anything different. And the beauty of this new calculator is that you can share their screen with the patient, showing them how the risk is, how that risk really translates to the lay terms, and how with the tiles on the screen, how they can bring that risk down. You have even options to click on and show them how quitting smoking or changing the blood pressure would impact their risk profile, which makes the communication with patient and that motivational interview a lot easier for you. This slide summarizes everything that we discussed so far in just one slide, which is beautiful. Remember, there is no target blood pressure in this guideline. There is no target lipid in this guideline. For target specifically level for secondary prevention, you have to go to the secondary prevention recommendations. But any blood pressure over 160 on 100 requires blood pressure management. Any total cholesterol over 7.5 requires management, and it doesn't automatically put the patient in the high risk category. And I'll show you some examples of it. Even a combination of these two would not put the patient in the high risk. It can even sometimes, as an example I'm going to show you, still puts the patient in the low risk category. Yes, both blood pressure and hyperlipidemia need management, but in a patient who is otherwise well, the risk is not going to be intermediate or even high. It's going to be low. And the target, there is no target as like 4 with total cholesterol, 2 with LDL. In secondary prevention, you do have targets. In primary prevention, you will adjust the targets based on your communication with the patient and based on the risk. And there is nothing that is given to us as the target to reach. Let's move on. So any patient who we start on antipsychotics, we have to monitor for the first 12 months very closely, because we know about the impact of antipsychotics, majority of antipsychotics, on the metabolic profile, which includes blood pressure, weight, lipid profile, and they need to be closely monitored to assess the risk and assess the risk factors. So in the old guidelines, we know what we're going to do with our low risk, high risk, and intermediate risk patient. But let's see what happens in the new guidelines. I put all those features, all those numbers from old guidelines to the new calculator, see what happens. Interestingly, our 63-year-old diabetic patient who was on metformin with HbA1c of 6.7 comes back as a risk of 4% for us, only 4%, which is not a lot. And technically, she doesn't need to be on any medications. The intermediate risk person still is intermediate with 7%. So she would benefit from antihypertensives and statins to bring her risk level down from 7%, depending on which one she would benefit more from and depending on the discussion with the patient. And our low risk person in the old category still remains in old risk, even with the new calculator. So this is our low risk person, and this is the screen that you can share with your patient to explain how they can even bring the 4% lower by the things that they can do in their lifestyle. Our intermediate risk person, again, you have a lovely screen that you can share with them and explain how things can change, like quitting smoking can bring the risk level down. And as you can see, our new diabetic patient, I mean, the old diabetic patient, but using new calculator now becomes low risk, which means that she may be able to come off her medications. And I show you how I've calculated the risk in different fashions. So the first time I tried to calculate her risk without putting the diabetic information in, and I said to the calculator that our patient is not on any medications for her diabetes, the calculated risk came back as 4%, which is borderline, but if the patient does not have any other reclassifying risk factor, which we're not aware of any, then technically she doesn't need to go on blood pressure or lipid modifying agents. If she's on them, you may consider taking them off the medications depending on your discussion with the patient. Next time, I decided to put the patient back on medications, but still saying I'm not going to give any specific information which comes under the diabetic section. This time the calculated risk was 5%, which puts the patient in the intermediate risk, which may justify keeping the patient on the medications for the time being because their risk is 5%, considering they are already on medication. So those numbers that we put in for lipid and blood pressure are with the help of medication. So that's why the risk is higher and there is less reason to take the medication off, to take the patient off their medications. Next time, I still kept the patient on the two medications, statin and antihypertensive, and this time I gave this calculator the diabetic specific information. I said the patient has been diabetic for 6 years, HbA1c has been in a reasonably good range, normal EGFR, normal body mass index, normal urine ACR, and no use of insulin in the last 6 years. And this time the calculated risk came back even lower in 3% because the calculator now knows that this diabetic patient has a very well-behaving diabetes. So the risk is even lower than what we saw in the past. And another time I told the calculator that no, the patient is not on any medication. And this time, again, I put the same diabetic information in and the calculator gave me 4% calculated risk, which again is in the low risk without any other reclassifying agent. The patient may stay off medication. So pretty much the answers were similar for this patient, but the interesting part was that none of those calculations gave us the high risk or even close to high risk, which is what we used to give this patient who was over 60 and diabetic. Let's see another one. We have this patient who is called Amanda, 56 years of age. She had a fasting blood test. Total cholesterol is 7.6 in old calculator. She would have been high risk straight away with over 15% calculated risk. In the new calculator, putting her blood pressure and the rest of the information in, interestingly, despite the cholesterol of 7.6, which the guideline recommends putting her on statins, the calculated risk is only 2%. So we know that she's low risk, but the guideline says that that level of high cholesterol ideally requires medication treatment. We have an Aboriginal man called Robert, 61-year-old Aboriginal, type 2 diabetes, good blood pressure. His total cholesterol is 4.6, not ideal, but okay. HDL is 2.4, which is really, sorry, LDL is 2.4, HDL is 1.4, which is again good. It's above the usual recommended level. We calculated his risk without his diabetic specific information, and the risk came back as 7%. And I thought in real world, if I know that this patient is a smoker, is Aboriginal, is diabetic, and his calculated risk is 7%, considering his reclassifying ages of a factor of Aboriginal background, I would be keen to send him for coronary artery calcium scoring because that would help me to reclassify him to high risk and put him on statin and antihypertensive. So the correct answer here would be he would potentially benefit from coronary artery calcium scoring because it makes us more comfortable to push him to the high risk and start him on medication. Next time I use the calculator again for our patient called Robert. And this time I explained to the calculator that he's got a very well-behaving diabetes in the last 5 years with a good HbA1c of 6.5, normal ACR, normal body mass index, normal EGFR, and no use of insulin. And this time I had a better result of 4% risk, which gives me this time maybe less reason to push him through the coronary artery calcium scoring, because that may not change the outcome. So you can see how much giving more information to the calculator would give you more specific results. I played with the calculator a bit more, and I think you would be interested to know what happened. I put a sort of imaginary patient in the calculator, 48-year-old woman. I put the systolic blood pressure at 165, and the recommendation of this guideline is to start treatment for that level of blood pressure. But interestingly, without any other, screaming risk factor, her calculated risk was 1%. So yes, we still treat the blood pressure, but she's still in the low risk, really low risk category. I haven't come across a 0%, to be honest. So this is the lowest risk. I decided to go a bit further, and this time I had a patient, similar 48-year-old woman. This time I said the systolic blood pressure is 185, which is really high and does require treatment. And I gave the, what else did I do? And this time the calculated risk came back as 2% with 100. So I only changed 165 to 185, and 1% only went up to 2%. And next time I pushed the blood pressure still to 185 and gave her a total cholesterol of 7.8 with an HDL of 1.3, which is okay, but not overly high. And I was really expecting to see this time at least a high risk result. And interestingly, the calculated risk was still 2% for someone with blood pressure of 185 and total cholesterol of 7.8. This patient does require both antihypertensive and statin by the guidelines, but would not be in the high risk category. So that's interesting. So that's the summary. All in all, I personally like the new guidelines better. I think it's kind of it's safer to use because it doesn't have many reclassifying agents outside of the calculator page. It counts for more risk factors. It makes the communication a lot easier, but it may have completely different results to what you were expecting from the old calculator. So please use it. Like I said, it's based on more Australian and New Zealand data, so it's closer to our demographics. And hope you enjoy this new calculator and the use of it for your patients in your practice. Thanks for listening to me. Bye for now.